Okay. So healthcare doesn't break in the ICU or the clinic, it breaks in the handoff. The moment the baton leaves one set of hands and hasn't quite landed in the next, that's where the patients, families, and clinicians feel the chaos. Joining us today is Alex Bardakh, Senior Director of Advocacy and Strategic Partnerships at PALTmed, and someone who spends a lot of time untangling how federal and state policy actually lands in the real world. Alex understands the policy, the reimbursement, and the clinical reality of post acute and long term care, and how those forces ultimately shape transitions of care. If you care about care coordination and value based models, or just want to understand why the baton drop keeps happening and how we fix it, this is the conversation you want to tune into. Welcome, Alex. I'm glad you could join me today on the relay.
Well, thank you. That was extraordinarily beautifully said. I appreciate that.
Yay. So I want to just dive in because the big, what's going on? So let's start with the big policy storyline. So the House just passed its version of the ACA reform bill, and then the update to it this week. Do you think that the Senate is going to move on its own version by the deadline? If so, what do you predict it will actually look like, that bill?
Yeah, thanks, Val. I think well, those of us that have been in DC the last several years have learned not to make steadfast predictions about what's going to happen because we all know that things change hourly, daily, etc. Social media has played such a huge role in the role of policymaking, etc. So it's hard to make a prediction, but I think we can describe what I could do is describe sort of the parameters that will govern that decision by the end of January. And so just to level set, I think, Val, what you're kind of describing the current situation is we are once again up against this deadline to fund the government or the government shuts down again. Unfortunately, we don't have to explain what that looks like because we just went through the longest shutdown in the history of the country. And so I think everybody understands what that looks like. And given that, just my view and in speaking with others, of course, is that nobody has that appetite to go through that again. There are too many policies that get disrupted. There are too many essential services. We saw that with aviation, for example, et cetera, et cetera. That just brings to a halt too many things. And I don't think either party going into an election year is willing to take the risk of another government shutdown. So what is
Into
the,
my mind,
what's that?
that's the first thought that goes into my mind as well, that nobody wants to touch that again.
Yeah, I agree with you. I don't think anybody wants to touch that again. I think would be a lot of concerns about what that means to the electorate in next year's elections, et cetera. And so, what does that mean? That means that somehow they have to come to an agreement on a package that will fund the government for some period of time. We don't know what that looks like. It literally could be a continuing resolution for another month, or it could be for a year. It could be for a number of things. What we do know is that the House did pass their version of the Affordable Care Act subsidies extension, and perhaps somewhat surprising, it's a clean, if you will, 3-year extension that enough Republicans came over to vote with the Democrats and pass the bill. Now, of course, it goes to the Senate, where the math again is very complicated. And the stakes are very complicated. So the Majority Leader John Thune, I don't think is going to. He had indicated it might not even come up for a vote. They might pass their own version. So it is far from any kind of a resolution. And we know that these bipartisan conversations happen, and not only bipartisan, but we have to have bicameral conversations because in the past, House and Senate had some kind of agreed on framework. We don't see that today, and I think that's what makes it difficult. And so we don't have a lot of time to go. We're sitting here talking on January 13th. It expires on January 31st. Something's going to have to happen.
Yeah, and that's the thing. What if it doesn't? What happens then? Insurance costs are going to skyrocket, and that's something that we wanted to touch on, because what if they just, what if we're wrong and they just don't care and they just vote not to extend it?
Yeah, I mean, then we face another government shutdown with, again, unprecedented or unknown length of shutdown because the fundamental issue of extending the Affordable Care Act subsidies remains on the table. And so we enter into the same kind of situation we were in the past where, we're in a shutdown.
So how many people actually will be affected by this? How many people actually use those subsidies?
Well, I think there are different numbers. I've heard 14 million to 16 million people that are using this. There's a lot of people who are on these exchanges. That also impacts not just those that are using the subsidies, but the people that are enrolled in these exchanges because the whole system may collapse if we don't have this in place. So I think you're talking about low-income folks that are utilizing the subsidies, but you're talking about everybody else who's utilizing the exchanges. So I think that number is significant enough to where it would be a significant issue. If you recall, in the previous shutdown, of course, there was a threat of an increase of these premiums. It's beyond a threat now, and it would really be an issue.
Yeah, I mean, but the thing about it is some people say that the latest CMS data shows that fewer Americans are signing up for the
Mhm.
ACA marketplace plans year over year. Now,
Right.
right now, it's largely due to the expiration of those enhanced federal subsidies, but many people will say, if you think about 14 million people in the grand scheme of 350, 360 million Americans, we're not really taking care of the whole country. So what kind
Yeah.
of plan can we do for that?
The issue of sort of the bigger picture issue of the cost of healthcare in this country. I mean, you look at, just even outside of the exchanges, but you look at even employer-sponsored healthcare. The cost of healthcare is at the heart of all of this, and the fact that even under employer-sponsored healthcare, a lot of people cannot afford it just because the premiums are so high. And so I think the bigger issue of affordability, and that word's kind of become another kind of political lightning rod, but the affordability of healthcare in this country, much bigger than just the ACA subsidies, is a big issue. And I think, to the point that we talk about here, a lot of that stems from the fact that are we utilizing the services in a way that is the most efficient, right? Our drug price is too high. There's so many different factors that drive our healthcare costs that you're absolutely right. It goes well beyond sort of the issue of subsidies.
And so because of that, I think everyone we talked about this on a webinar that you did for InTalk and value-based care. I think do you have an opinion on whether that will help the cost of healthcare? I mean, in the grand scheme of things, and if as everyone says, the future, I mean, I agree, future of healthcare is value-based care. Why are
Mhm.
we still grading the race with fee-for-service scorecards? Like, why not move that measurement system forward with value-based metrics that match where the baton is actually going by 2030?
Yeah, I think so. To your first part, I do think the value-based care, at least initially, and is showing that it can improve care and it can save a lot of money. You look at the preliminary or some of the reports from accountable care organizations, particularly those that are serving high needs patients, and they are showing positive results. I think patients at the heart of value-based care, of course, is these handoffs and the idea that you don't just discharge a patient from one setting to the next and forget about them, that you follow up, that you actually worry about whether or not they come back to the hospital, whether or not they have a physician in the community, et cetera. So those are positive things. So I think you do have to at least hope that value-based care is the future. And every policy has sort of doubled down on it, right? I talked about this on the webinar, that regardless of the administration, multiple administrations from Bush to Obama to Trump to Biden to back to Trump, and yet this idea of move to value-based care remains, even though in general we are very divided on many policy issues. So I think there's a
Why
lot
is
of
it taking so
hope.
long, though? Like, I
Yeah,
don't
well, that was
understand.
my sort of get to that. Why does it right now? I mentioned, four different presidents, right? Like it would take, you'd think we'd get there by now. I think our system is just so complicated, and there's this great slide that shows just how complicated this system is. I think our system is so complicated that it is very difficult to move everybody along. And you think about what has to happen in order for all of this to move. It sounds like, just value-based care, but it's about data exchange, right? It's about setting up these health IT systems, and we know that that's been particular challenge. It's about establishing the right quality measures. You touched on it a little bit. Well, it takes a lot of money and a lot of effort and a lot of time to develop and make these quality measures what they're supposed to be. And so there's been a lot of work over the last more than a decade, probably 2 decades now, in quality measurement, for example. So I think all of those things have to line up in order for the system to work. And it's just been an extraordinarily slow process.
It's like we have the right ideas, but the wrong way of paying for them sometimes.
No, I mean, and you're right. Like fee for service, the idea behind fee for service, of course, this isn't a new idea. Like in the 90s, we had the HMOs, right? And try to limit the market, try to focus on outcomes. But the problem was is there was too much finance and too little quality, right? And so that fell apart. I think what we're seeing is sort of the evolution of that, and then that we ensure that finances are tied to quality, because we don't want healthcare decisions to be just based on financial drivers, because that could lead to care that's denied or whatever. And that's the battle we're seeing play out right now, that we can talk a little bit about in the AMA plans and AI decision making and all kinds of things. So I think but fee for service in itself, you go to a doctor and you get paid regardless, and the doctor or the clinic, the facility gets paid regardless of quality. That's not the answer either, because anything that's driven by volume is just going to be just that. It's just going to be a lot of volume and not a whole lot of quality potentially.
Well, so how do you think AI plays into that?
Yeah, well, I think AI does have some promise in terms of improving our efficiencies in the system. You look at reports right now, and American Medical Association's talked about this, others have talked about this, that physicians and nurses spend, in an inordinate amount of time in front of the computer, right? They're charting, they're doing this, and it leads to so much burnout, not as much patient to clinician interaction, and it's not appropriate. And the reason they're doing that is because they're checking these boxes for quality measures. They're reading discharge summaries that are pages and pages long, and they can't discern what's the latest versus, what's historical data. So perhaps as we train these AI modules, on the positive side, perhaps the AI can take care of the documentation and the billing and coding and summarizing the discharge summaries and doing all of those things that we are spending hours and hours and hours of doing. So I think that's the promise of AI, is to allow clinicians to do what they do best, which is to take care of patients and allow AI to do sort of the administrative functions. So
It's
that's the
interesting.
promise. At least that's what I hope.
Yeah, it's interesting because before our call today, I was at the vet with my dog, and
Mm-hmm.
they had done some X-rays on her lungs, and the doctor told me what she thought, and then I thought to myself as I'm sitting there, I was like, you know what? I asked her, I was like, can I take some pictures of the? Can I take those
Mm-hmm.
X-rays and put
Mm-hmm.
them into AI?
Mm-hmm.
And I did that, and it told me exactly what the doctor had told me and a little bit more. And I showed it to her. It was kind of like a little
Right.
experiment. I
Yeah.
do believe that we have to have personal human input because you can't just trust AI all the time.
Right.
And that's my fear with AI, is that
A
people
hundred
are going to
percent.
just be so dependent on the answer that it gives and not do any research and make sure that it's correct, or like if it's doing your notes for the doctor and it misses something or it doesn't transcribe something right, or it just, but that happens with doctors not transcribing things right either. So it's just,
Yeah, we
I
have
don't know.
too many errors as they are. That's absolutely true. But I talked about the positive of AI, but there's a flip side to it, which is what you're talking about, and that is, I think everything. I've always been taught that everything is good in moderation, right? Like too much of anything is not necessarily a great thing. I think that applies to AI as well. I
Yes.
agree with you. Like I think that, and I talked about this. I did this keynote at our California chapter. And I talked a lot about AI. And the thing about it is that AI is a series of ones and zeros that pulls data, that pulls information, and as I already mentioned, can aggregate it. But it's the aggregate of that information is only as good as the information that it's aggregating. And that's where the trust issue comes from, because you have to get it from a trusted source. The other thing AI cannot do, which all clinicians do, you mentioned radiology and imaging and things like that. Look, if you're diagnosed with cancer, and you put it into AI, and it spits out that maybe you have a cancer cell or whatever it is. AI doesn't do emotion. AI doesn't do care. AI doesn't do handoffs. AI is a computer, right? I grew up playing chess, and Gary Kasparov, who I listened to back in 1997, I happened to play him that year that he played Deep Blue, and he talked a lot about this. I wrote about it. And he talked about, computers don't get tired. Computers don't have emotion. And I do think that there is an art to medicine. When you get diagnosed with cancer, I think you need to speak and understand what it's all about, the plan of care. It's not something you're ever going to get from a computer. The other thing is that it absolutely can be wrong. And I think that's why we need to have trained clinicians who can either verify, who can look at it. It could potentially give them. I listened to a speech by Dr. Fagenbaum. I don't know if you know who he is. He's fantastic if you have time to look it up. And what he's doing is very interesting with AI, for example. He's matching medicines that have never been used for a particular disease state to see, to use AI to see if they can match it to rare diseases. He has a long history of doing this, and it was fantastic work, but it's being overseen by somebody who understands what they're looking at. And,
Right.
and I think that's the important part.
Right, like today. And the thing with me, I was like, she was like, I can't really see it. And I thought to myself, you know what? AI doesn't have eyesight problems either. You know what I mean? It doesn't lose its eyesight. So it can dig in and see the things that maybe we can't see.
Right. I think that's right. Or don't have time to see, right? I mean, it takes,
Right.
just think about the volume of information that we all deal with on a daily basis. In today's
And
day
the
and age
amount of
where
ADHD that's in the country right now.
exactly, there's
Attention to
just so much
detail.
information. And how many of us, somebody who said this, like, basically it's like reading a lot of cliff notes. Like if you had a lot of books and you could summarize them and read the cliff notes. We've had cliff notes for years, and I remember being in school and reading
Mhm.
those cliff notes, right, to trying to pass a test if I didn't have the
Yep.
time to read the whole book, right? So I mean, but you have to be careful, right? Use it correctly. And I think there's a lot of ethics conversations that are happening within AI. I think there's a lot of really concerns, as you said, but there are people who are using it, and there's a lot of promise. And what's that middle ground? I think we're going to find out in probably pretty short order because it's moving very, very
I
fast.
mean, it is so rapid. Like I remember 2 years ago, I was fighting it. I was like, "No, it's gonna take over the world like Judgment Day," you know?
Right.
And then I'm using it myself and I'm like, I have become more intelligent in the last year than my whole 50 years of life. It's craziness.
Like kids are learning this, right? They're
Yeah.
growing up with this now. Like for us, it's something we had to learn. But as with everything, like I'll give you an example. So I have my son is 6 years old, my daughter's 9 years old. And just recently, Amazon released its Alexa Plus, right? It was like their new voice and all this stuff. Well, they upgraded all our Amazon to Amazon Plus. And I was here sitting here upstairs and they were downstairs and they had and I kid you not, they had an entire conversation with Alexa Plus, like a full on conversation, meaning of life, and it just, if nobody's done it, like just go do it. It's fascinating. And afterwards, my son came up to me and he goes, "Oh my goodness, I can't believe I just had the most interesting conversation with Alexa." And it's second nature that you could talk to a microphone
Right?
or a video screen, and it gives you advice on just about anything, including what 6-year-olds care about.
Well, and that's what I'm saying. Like it is like it has the opportunity to make us smarter human beings quickly.
Hmm.
Quickly. And it also has some kind, it's not a human touch, but some, because this is what it said when I uploaded the radiology pictures. Thank you for sending these, and I know you're exhausted from dealing with Fancy's medical stuff. I mean,
No,
it's like
I talked about that it doesn't have emotion, but it does learn and it tries, right? I mean,
yeah,
I don't personally think that anybody could ever match human emotion in a way that humans touch and all. I mean, listen, I'm saying this now, we probably can't even dream of what this is all going to be. As we sit here today, that's my thinking. It could evolve. I don't know, but it is fascinating where it could
it
all
is
go.
very fascinating. I will agree with that. So I wanted to touch a little bit also on PaltMed's actual population. What parts of the handoff break most consistently?
Yeah. So at PALTmed, of course, we represent the post-acute and long-term care clinicians who see patients in nursing homes. So I think the answer shouldn't surprise anybody. And of course, that's the transition from hospital to the SNF or SNF to hospital. And it's really setting to setting. Those transitions, we know that there are medication errors. They are not great for anybody who resides or is a patient or a resident in a skilled nursing facility or a nursing home. And that's because, again, we don't have the interoperability. The data does not get shared. The Epics of the world don't speak to point click cares or whatever it is, or not in the way that's the way that we think should happen. We just talked about AI. Like we could check our bank records and stuff anywhere, but we still don't have that in healthcare. And so that's really the breakdown is, do the people in the hospital setting really understand what happens in the nursing home and vice versa? I hear this debate all the time. They blame each other for the diagnosis of UTIs, right, or whatever it may be. And so that kind of gap still is yet to be filled, if you will. And then, of course, you bring in home health, you bring in other areas, you bring in pharmacy, you bring in all kinds of things. And that's where really it breaks down.
So, people say interoperability is a problem, but do we have other problems like moved into behavioral and workflow problems like instead, like burnout or um, policy mechanisms that could actually change behavior at the bedside, things of that nature.
Yeah, well, I don't. So interoperability is a problem in a sense that I don't know that it's at this point in time a technological problem, like can they solve for exchanging data? Of course. I think the issue there is standardizing that data. What language is it using? There are, proprietary things that each of these electronic health records are concerned about. There are privacy issues. We see they're just HIT rules that just come. There was just a new one about that address privacy, for example, and all kinds of things. So I think there are questions in the interoperability world that are just beyond the ones and zeros. I think certainly if this was a technology problem, we can solve it, because I think there's no way that somebody from Silicon Valley or whatever, Google, Amazon, your Epics, et cetera, can't figure out how to solve for the technology problem. I think the problem is to match that technology with the clinical, and I think that's been the challenge. We've talked about quality measures, we've talked about all these things, and so they have to be documented in very similar ways. Otherwise, yeah, that information breakdown can occur. And then the other thing is that even if you do exchange that information, is it searchable by the receiving party, for example? Is it usable by the receiving party? So when we say interoperability, I think a lot of people perhaps hear like, it's just a technology problem. And what I hear from vendors, and I went to a couple of conferences, NetSmart, Point Click Care, SI Systems, you name them. This is not any vendor to promote any vendor or speak about any vendor, but all of them understand the technology. These are smart people that have grown up with this. But it's really the marriage between the technology and the clinical aspects of care that are difficult to marry, if you will.
So I also wanted to touch on a little bit of this because this is a huge problem. Over 150 rural hospitals closed, and many states with high rates of chronic illness and limited post-acute capacity don't have these hospitals anymore. So that and the older population can't get out and drive 100 miles to a hospital. Or how do we combat this? How do we fix this? I know that's a
Yeah,
big
well,
question.
obviously rural health is a huge issue. And we talk about all this technology, we talk about all these things. We haven't even touched on broadband. I mean, we assume, and I heard this conversation the other day, we assume that everybody has strong Wi-Fi and everybody has the broadband necessary to. But I've heard from nursing homes, they are still on dial-up internet. They're still doing AOL, right?
That's
Like, it's not
crazy.
AOL, but you get my point. It's not strong enough to do telehealth and all these things.
That's
Believe it or
crazy.
not, that still happens in this country. I think that's a challenge in broadband, and that's, I think, something we need to address. But I think one of the positives recently is an announcement for the rural transformation networks. I'm not sure if that's exactly if I'm stating their names exactly, but it came out of legislation that providing grants and funding for rural health. I know Maryland, where I'm from, has received that as well, and so that's supposed to focus on rural health, and I hope that they address things like broadband. We need to address clinician shortage in these rural areas. Where I come from in the post-acute long-term care world, we do not have enough physicians, medical directors, trained nurse practitioners to take care of this population. It's just true. We hear from rural areas where there's one physician who serves multiple counties in a rural area. And we know rural areas, they are not small. Like, it's not about an hour, a half an hour drive. We're talking about just areas that are very distinct, very far, and yet there are nobody in some of these areas trained enough to take care of them, and that speaks to our workforce shortages. And AI is not going to, we talk about AI, it's not going to solve for that.
No, and that's it just makes you so when you talk about all this and all those hospitals that need funding, and it really kind of goes back to the whole why are we spending so much money on these subsidies for only a tiny portion of Americans? Like when we have rural hospitals shutting down and no access, and it's just crazy because we're not taking care of the complete population.
Yeah, I think it's a multifaceted problem, right? So, and that's been a discussion as well. Just because you have coverage doesn't mean you have access, right? So you're touching on sort of the flip side. So just because I have health insurance or through subsidies through Medicaid, whatever, it doesn't necessarily mean that I have access to care, because if there's no physicians in the area or nurse practitioners in the area, they're either accepting a Medicaid or they're just not there. So we have to ensure that there is access to care, and it gets into Medicaid reimbursement rates. It gets into all kinds of things, and I think that's why you see these fights around managed Medicaid, right, to try and get Medicaid into value-based environments as well. So I do think that the problem is multifaceted. One is you do need to have coverage of some sort, and you need to have subsidies in order for people to be able to afford the insurance. But then you need, on the flip side, you need to make sure that they are worth something. right? That they're not just, I have coverage, but I don't really have any access to care. I think both need to be addressed.
I agree completely. Because it makes no sense. Sometimes you just you look at yourself with all this going on, and you think, you know what? Let's just give the states this much money and let them deal with it.
Yeah, I mean, I think you get into the details of how things are set up. I mean, there's been conversations, for example, you have Part A that covers facility costs, you have Part B that covers, physician costs, Part C, the MA plans and drug costs. And so we've sort of divided things, and things are siloed. So we talk about value-based care, but historically we have divided the Medicare and Medicaid, particularly the Medicare and Medicaid programs, into all these distinct parts, and they're governed in very different ways. We see this particularly in nursing homes, where Part A covers the facility side, Part B covers the physician payment side, and they do not have the same quality measures. They do not have the same incentives, and that's been an issue as well. So, do we need to relook at the system as a whole, not in these different parts, but to your point about, that to ensure that the people that need the care have the coverage they need to get it, but on the flip side, that we have the reimbursement that's not delineated into these silos. Now, it's not an easy thing. You talk about how long it's taken us to move into value-based care. I think it equally as long to talk about, what is Part C and B and A, and it's very confusing to patients as well, who deal with day in and day out, like what's covered by Part A and what's covered by Part B, and where is my drug coverage, and et cetera, et cetera. I think it's very confusing to people.
Oh, let me tell you, I know it's confusing because my dad, before he passed away in April last year, or the year before that, I'm sorry, before he passed away, he was in a nursing home, opioid addict, long time.
Mm,
But the thing is he had lung cancer, and when they found it out, they put off his oncology stuff
mm,
until they could get his speech therapy under control because
mm.
they couldn't use both parts of the Medicaid at the same time. And I had to step in and say,
Yep.
"Hold up. I'm sorry, but the cancer is way more important than the speech therapy." And
Mm.
it was just like insanity. Like it made no sense to me at all. Like so I had to
Yeah,
step in
no,
and got that all. But anyway,
yeah, it's crazy. I do think that we talk about the breakdown in handoffs. I think because there are some concerns around, well, that's a Part A issue, that's a Part B issue, that's a drug issue, that's part, whatever they have, Medicare Advantage, whatever it is that they have, that there's a breakdown. And to your point about like what happened with your dad, and I'm sorry to hear that. Yeah, that happens all the time to people. We tell me, we still have an archaic 3-day stay in the hospital and all these other things that are just so irritating, not irritating, but they are confusing, and they're real life, because think about the energy that you spent. And you could have the best nurse practitioner, the best doctor, the best care, and yet if you are frustrated trying to figure out what covers what and fighting for that, what is your experience going to look like? Are you focused on his goals of care? What does he want to still achieve? We deal a lot in hospice. Like, what is your goal? Is your goal maybe to see your daughter graduate or granddaughter graduate, whatever? And so I think those things are very important. We should be focused on that kind of conversation, rather than, oh my goodness, is my SNF stay going to be covered because I don't know if I was classified as an inpatient in the hospital or under observation status, or whatever, any number of issues, or is speech language covered by this or oncology covered by that. We only as human beings have so much energy that we can give out,
and so
and I
much
think in those
capacity
moments
for
that
it.
are difficult, we want to give all of our energy to be with our loved ones, to take care of them, to uplift them. And when we got to deal with all of this, that's where that handoff, that's where that care just breaks down, because we don't have the energy to think about the care, because we're dealing with the sort of the what's covered where, and the phone calls and et cetera. And it's not good for anybody.
And you're gonna have to have an insurance yourself just to take care of you when you go in the loony bin because of dealing with all this
Well,
stuff.
you just mentioned the lack of behavioral health. I mean, you're lucky if there is a loony bin. But um,
That's so
yeah, I
sad.
think behavioral health is an issue. We see behavioral health issues in the nursing home all the time, and that's an area that's a whole separate kind of ball of wax. And again, is that I think the promise, getting back to value-based care, I think the promise of value-based care is that we can provide the services that promote the best outcomes quality wise, right? Either quality of life, quality of care, and and that leads to a more efficient, cost effective system. So I think that's, if you want to talk about the utopia is that we are providing, we speak about the goals of care. We're providing that care in a way that's holistic, that we don't have to spend 50 different phone calls about part A, B, C, et cetera. We're providing that holistic care. And because we're doing that, the patient's happy, the caregivers are happy, and we're saving dollars. To me, that's kind of the utopia of where we could go.
Right. It shouldn't be that every person you talk to has to deal with this stuff. Like, and it's for minimal things sometimes. Like, it's just insanity that we have to deal with all of this. It should just be you go to the doctor, you get better. It shouldn't add an extra layer of your life, that you gotta focus on this over here for three
Yeah, and
hours a
sometimes you
day.
don't
You
get
know what
better.
I
Look,
mean? Like,
we deal with hospice, and deal with end of life issues. Sometimes it might not be about getting better. I just want to stress that, like, sometimes it's about what your goals of care are, or
hmm
goals in life, and that's what we're focused on. Hopefully, for the majority of the population, right? Like, it is about getting better, getting out, doing things, but whatever it is, I think we have to be, the word patient centered used to be this thing. Now we talk about person centered, and all these things. But yeah, to truly what that means, I think, is that we're not dealing with what we just talked about, but we're really dealing with the person and who they are, rather than what's who's their insurance and all this other stuff.
well, because as horrible as it sounds, you do have to ask that person, what do you want? What is your
Right.
outcome? You just want to be comfortable or do you want to solve the problem? Until, you know what I mean? Like, some people don't
Mhm.
want to go on. Like, and I'm not talking about Kevorkian and stuff. I'm just, you know what I mean?
Yeah.
I'm just talking about, like, some people are just like, I'm done. I just want to live out my days.
Yeah.
And then you've got the family over there pushing to get them better and take the meds and all this stuff, but that's not what they want. So I think that has to also, that plays in the outcomes as well.
Yeah, I just, as you said that, I've talked about that in terms of AI. You remember AI is ones and zeros and spit out what they think is based on the algorithm. Well, that might not be what you just talked about. It might not be your wishes. So,
Right.
how can AI? That's, I think, where we need these compassionate folks that understand and can provide you the care that you need in order to comply with the goals of care that you have. And not, I keep thinking always to this iRobot situation, right? If you watch that movie, where it's making a life and death decision based on an algorithm, and I'm not sure
hmm
that's a world that we want necessarily.
But it does take emotion out of some other things, though. Maybe not
It's true.
healthcare.
Yeah, there's a positive to it. Absolutely. No, I mean, we deal with that all the time. Families that disagree, right? And I think the goal of advanced care plans, right? All of that. And that needs to be, talk about interoperability. Advanced care plans need to be shared and accessible. It shouldn't be written. I mean, it can be, but somewhere on a napkin where we can't find it, right?
Right.
It should be transferable. It should be well understood, et cetera, because there's so much care, and talk about handoffs and breakdowns, that they get into the nursing home and the advanced care plan is nowhere to be found. And families arguing and all kinds of stuff. That's not
I
great
don't
either.
I don't even have one. I mean, I know that that's something for, we think, older people, but I don't have it. I don't
Not,
think it is anymore, is it? Because it could happen
no.
any day. You could need it any day.
Well, what people, and I've talked a lot with organizations that deal with advanced care planning, and we do as well. What people need to understand is it's about your wishes of care, and our healthcare can change at any moment. We all drive cars, we walk down the street, we have beating hearts and working organs, and we don't want to necessarily think about those things. But it's not about somebody who's dying in a nursing home or hospital bed, because that's the wrong time to deal with that. As you said, there's a lot of emotion. You want to deal with it when you are sober, if you will, and you have your family and you can discuss it and everybody understands it, because it's not a crisis conversation, right?
Yeah. Well, Alex, I want to thank you so much for coming today and joining me for this thoughtful breakdown of the policy landscape and what it means for care coordination and transitions of care. We appreciate your time and the work you're doing with PALTmed and InTalk, because you're also on the board of InTalk. But for everyone joining us, this is a conversation we'll be continuing throughout the year. I hope Alex will join me maybe once a month or every couple of months,
Mhm.
and we'll get policy updates from DC to continue this conversation and make sure to share those resources with everyone listening.
Well, thank you, Val. I think this has been great, and I'm happy to continue the conversation. it's one we all need to continue to have.
Well, I'm going to hold you to that because this is exactly the kind of conversation we need to keep having out loud. Policy can feel abstract until it collides with a real family, a real discharge, a real handoff that either works or doesn't. So for everyone listening, if there's one takeaway from today, it's this. Value-based care, AI, rural hospital closures, Medicaid, and Medicare alphabet soup, none of it lives in a vacuum. It all shows up in that fragile moment when the baton leaves one set of hands and hasn't quite landed in the next. That's where people either fall through the cracks or get caught. We'll keep bringing voices like Alex's back to unpack what's moving in DC, what it means at the bedside, and what has to change to make handoffs safer, simpler, and more humane. If this conversation was helpful, share it with a colleague, a caregiver, or someone in your policy world who needs to hear it. And make sure you subscribe so you don't miss the next leg of this relay. I'm Val Emmons, and this has been The Relay. Thanks for listening, and until next time, keep your eye on that handoff.